This is Dana Dunleavy back from Buffalo, New York. Lucky to be here with Blake Parsons. You know, we talked with Doug Beal in the past, and most of things interventional spine tend to live on the MSK podcast. But really, we realized there's a huge gap and need to talk, about our foundation as vascular interventional radiologists. And all of your talks and episodes have been really on the vascular side. So what are you doing here now?
Yeah, I guess it's kind of funny how we got started, which, by the way, I know Doug Beal very well. He's here in my hometown. I've probably known him now for about 15 years. Fantastic doc, and obviously a great person. So I rotated with him, man, back when I was an intern, I think a long time ago. And honestly, that's what got me interested in the outpatient model because he's had an outpatient based practice for a long time. But to bring back, so spinal cord stimulation, how did I get started? Honestly, where I trained at Medical College of Wisconsin, we had a little bit of a unique service in that we spent a month on palliative care. And, obviously there's a huge interventional oncology aspect to interventional radiology. So we were able to do a lot of the blocks and those type of pain interventions on a lot of those pain patients. So I'd already kind of had a little bit of a base of that. And so when I got out, I was probably in practice maybe a year, and I had some pain management docs reach out to me where they were doing trials in their office, but they didn't want to do the perms because they didn't have ownership at an ASC and it didn't behoove them to go to a hospital. So there it wasn't really worth their time for the reimbursement. And they said, "Well, do you want to do the perms for me?" And I said, "Okay, sure." So I probably started doing really perms out the gate before I even did trials. And that was probably about 5 to 6 years ago now. And so that's how I first kind of got into it, and got exposed to the space.
Well, that's fantastic. I mean, that's the opposite, right, of most people that think, yeah, I guess maybe I could pull off a trial, but a perm sounds so scary. Can you take it down to, what a perm means to you?
Yeah. So, I mean, this space and getting epidural access is, I mean, for interventional radiologists, this isn't a hard task, right? I mean, where you're quote unquote, I guess, needle specialists, we're supposed to be good with our hands and be able to feel what tissue planes the needle's going through and all these things. So being able to get access into the epidural space is really not that challenging. And that's the most challenging part of the whole procedure. The permanent part of it, it's essentially just a glorified infusion port, right? You're just making a larger pocket and you're doing it in the supragluteal region on whichever side the patient wants. You do have to make a little incision at the access point at the lumbar spine where you're going to stick the needles because you got to be able to place the leads, tunnel them completely under the skin. So I think that's probably the biggest scare is that incision, and that you've actually got to kind of feel like a real surgeon and do a little bit of cautery and cut down and work your way down to the interspinous ligament. And believe me, when you're doing, I think my first one was a very high BMI lady that I don't know why I took as my first one. And when you're about hand deep in their back and you're wondering where the heck the aorta is, because you've got to be getting close, it can be a little nerve wracking. But there's nothing back there, right? It's just subcutaneous fat. Their or paraspinous musculature is back there, but you'll know when you get to it. So it's really, I think, more scary, and because it's not part of our initial training. And so you think of it as like, oh, this is outside of my realm. But when you think of the vast amount of different things that we do as IR doctors, it's really not a challenging procedure, something that's just way out of your expertise.
It's a great point. And, sometimes we hear from our colleagues in other specialties that will talk about either a trial or a permanent spinal cord stimulator taking them a lot of time. And what they mean by that is they just couldn't get the needle in the epidural space. For us, really, that's pretty effortless, and whether that is, our gift or just that we have good imaging. I think either way, it's not that challenging. How do you look at it, just sticking with the perms for a second, to compare that to a Metaport? I mean, unlike Doug, you're kind of a standard interventional radiologist that did a body interventional fellowship, and you've spoken about interventional oncology before. I look at jugular access, tunneling, pocket, and here it's epidural access, tunneling, pocket.
Yeah, and you're not even accessing a blood vessel. So, I mean, obviously the epidural space is scary to people because I think the big concern is, okay, well, what if I poke into the thecal sac? Well, we get into the thecal sac all the time to be able to do samples. Now you're using a much larger needle than what a 22 gauge, obviously. But that being said, your risk is still low. I mean, a spinal headache. But I think the other is people are always concerned, are they going to cause a nerve injury? Could you potentially cause like a bleed down there that could, impinge the cord or cause some kind of neurologic effects? I will tell you that the risk is low. And to your point with the skill set and being able to use image guiding to our advantage, which is basically our whole specialty, it really is a much simpler procedure than what most people make it out to be. The permanent spinal cord stimulator pocket's about 3 to 4 times bigger than what you would make a port pocket, and again, it's just in the subcutaneous tissue. The hardest part of the deal is for us is probably just sewing the pocket up at the end just because it takes us a little longer because, we're not spending all day like my vascular surgery partners sewing all day long. So, of course, I get harassed and made fun of from the windows about my sewing skills, but we get through it. I tell them it looks better than theirs, so that's all that matters to the patient.
Yeah, and so, for a lot of our colleagues, they may wonder about site of service, RVUs, reimbursement. It seems to be, even though I would say that we're all focused on efficacy, a lot of people are feeling more RVU pressures now. Have you ever looked at RVUs of Metaport versus spinal cord
Well,
stimulator?
I don't have the exact numbers, but it's gonna be a big, big multiple on the spinal cord stimulator versus the, Metaport. Like, for instance, putting in a port somewhere around 2 to 3 grand probably in a, outpatient setting, not at the hospital. At the hospital, you're gonna get paid, obviously, hospital rates, but, a spinal cord stimulator, a trial, and now we can get kind of into that as well. There's a big difference even on the trial or on the spinal cord stimulator on the trial side from doing it in your office versus doing it in a surgery center. Most pain guys do them in their office because they're there, it's fast, they put them down. Now they're going to get paid about $700 to do it in their office. A leads, they're out a couple $100 for 2 leads. So for the time it takes them, it's decent revenue. If you do that same trial in a ambulatory surgery space, you're looking at more around like $9,000, even a little more depending on what state you're in. So there's a much bigger margin, obviously, in the ASC. Now, to do the permanent, it has to be placed in a surgery center. You cannot do a permanent implant in an OBL setting. And that also, it's going to vary based on your volume and what you're getting your generator pricing at, but you can roughly figure it's going to be also somewhere around of a margin to around $10,000. So, if you're doing a trial and a permanent and you're doing them both in a surgery center for, a commercial paid patient, you're looking at around 20, a little plus 20 plus $1,000 of profit. That's after costs. So,
Right. Yeah, and to your point, the trial is practically free, right? I mean, it's one of the lowest cost procedures that we do from supply standpoint. Going back on that, one of your prior episodes, you were talking about prostate artery embolization, and that, when we're all getting started, it can seem like it might not be the best utilization of our time. One of the things people talk about with trials is that, just very simple and predictable procedure. Thoughts on kind of the time utilization?
yeah, I think doing a spinal cord stimulator trial now, obviously, there's a little bit of difference if they've had extensive back surgery history. You can run into some more tricky because they get scar tissue in the epidural space. But a patient who's basically got let's say, a virgin back, so to speak, and you're going to do a trial on them, yeah, we'll say in and out 25 minutes. That's prep time, get them on the table and everything. It's a 10-minute. But all you're doing is you're getting fluoroscopic guided imaging into the epidural space. You're going to run a lead up to this place, depending on where their area of coverage you're trying to get. You're going to then access it again with another needle, which the second one always seems easier because you've already kind of tinted the epidural space and it's ready to go. You can do that kind of in a side-by-side fashion on the same side, or you can do it where you have access from both left and right sides into the epidural space. It doesn't really matter either way, whatever you're comfortable with. But then once you put those leads in, you're done. I mean, then you tape it to their back and they hook the leads to the generator, which all gets taped to the patient's back for the trial. And that's about it. And the patient, obviously, the beauty of these procedures too is versus all the other things we do is the rep doesn't just show up and hand you your stuff and leave. This rep is now married to this patient, right? So the patient's continuously getting checked on by the rep every day. They're updating you. They're dealing with all of their programming and everything like that. I do zero programming. So when these patients come in to see me for follow-ups, the rep is in the clinic with me. They know when my patients are in and scheduled, and they are the ones managing the stimulation part. Obviously, I'm still speaking with the patients and making sure they're doing okay and all of that. But so that's another kind of bonus procedure as well. From a timeline standpoint, just to kind of enter it now, the perm, I'd say add another 30 minutes or so at least. It's probably an hour to do a permanent placement, especially in the beginning, just because you do have to sew the pocket. It's going to be a multi-layer sewing or closure, especially in the back part probably. So until you get quicker at it and all that, it's going to run you a little bit. But still an hour case. I mean, that's pretty typical for any IR case.
Yeah, and just one thing on the reimbursement, I think that your numbers all sound good, except many places in the OBL probably have about 3,000-4,000 for their OBL reimbursement for a trial. And as you know, the supplies aren't much. So for many interventional pain docs, as you noted, they're pretty happy just doing trials and not even bothering with perms. But it's nice that you're able to do it all.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTableMSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Jamila Kennebrew.
Thanks again, and see you next time.